Yeah. All right, good morning. It is Thursday, February 19th, and this is the Senate Health and Welfare Committee meeting. We are looking at a bill that we've worked on a bit, S-157 on recovery residences, and committee, we have some language changes for that bill, so why don't we go through that together?
Good morning, Katie McGlynn, Office of Legislative Counsel. Here. That's okay. Here's the latest version of S-157. When we last met, we walked through changes that the health department have presented. So this incorporates those changes into a draft. So the bill as introduced had a section that created a voluntary certification program and outlined different criteria that would be required to obtain a voluntary certification. That section of the bill has been removed. Instead, in section 1, you're amending a existing definition section within the Title 18 chapter on opioid use disorder, or maybe it's the substance abuse disorder chapter. And you're amending that to add a definition of recovery residence. So recovery residence means a shared living residence supporting individuals recovering from a substance use disorder that provides residents with peer support, assistance accessing support services, and community resources for individuals recovering from substance use disorder. And then because we've added it in alphabetically, there is numbering that's happening for the remainder of that section. Then section 2 is an existing section of law that lists the responsibilities of the health department's division of substance use programs. And this list of responsibilities is in subsection B, and being added to the list is recovery residences generally.
So, okay, I'll ask. So it might be helpful. I'm glad Department of Health is here, and so might ask a question after we go through.
Section 3 was, and the bill is introduced, it had been section 2. This is the existing exclusions language that sets out what a recovery residence has to have in a written agreement with individuals who are staying at the recovery residence and seeking those services. There were some changes. One of the responsibilities is explaining the recovery residences programs, rules, and social standards. You liked that change. There was a discussion to use the word interferes instead of interfering to track how it was, to be grammatically correct with the rest of the subdivision. And you have that in 2 places. And then a definition of recovery residence in this section. This language in the bill is introduced had been struck through, and it referenced the definition that had been in section 1, which was the section creating a certification program. Because that section has been eliminated and now there's section 1 is an amended definition section. We're just changing the cross-reference number here so that it's cross-referencing the correct section where the definition is. This section 4 has not changed since you've seen it in the bill as introduced, but you do have a new section on rulemaking for recovery residence certification here. So on or before September 1st of 2027, the Department of Health shall file an initial proposed rule with the Secretary of State for the purposes of establishing a voluntary recovery residence certification program. At a minimum, the rule shall require that a recovery resident seeking certification from the state comply with the certification standards of VTAR or another organization approved by the department, and set forth minimum data collection and reporting requirements for certified recovery residences, including data elements and frequency. And then in subsection B, the department shall complete the rulemaking process and adopt a permanent rule pursuant to our rulemaking chapter on or before December 1, 2028. So that gives a 13-month window between when the initial filing has to happen and when the conclusion of the rulemaking process is occurring. I was concerned about just having a directive to start rulemaking and not finish it, because it sounds like you could just file with the Secretary of State and have fulfilled your obligation under the statute. So that's why subsection B is added. Then we have the same effective date language. So essentially, this is a change in who is determining the details for how certification is happening. The bill is introduced, had a statutory section where the legislature was coming up with the specific parameters for what would be required of a certified recovery residence. This rulemaking language instead is delegating a lot of that responsibility to the health department to come up with those specific criteria for how a certification program would be operated.
Questions for Katie on this? Okay, I do have a question. First, I'm gonna look to the Department of Health and ask you folks, do you want to come up and talk about this? Okay, thank you. You're welcome. Good morning.
Good morning, Emily Cooter, Department of Health, Provision and Substance Programs.
So, maybe just a general comment about what's included here and capacity to do rulemaking and oversee the, certification.
Sure. What I like about the rulemaking process is that it brings it onto a level playing field with substance disorder treatment services, with our recovery services organizations, and offers sort of a unified playing field for the service continuums. We do have the capacity in-house to conduct that process. And we are well versed and have recently gone through the rulemaking process for recovery service organizations. So it's also fresh. So I feel confident in my ability to be able to accomplish that.
They've answered my other question. Do you have the capacity right now to complete?
We do.
And then a third question you may not be able to answer, but I know with the Rural Health Transformation Grant, there will be RFPs going out. Will any of those relate to this work, do you think?
That is my intent. There are others above me who have to approve that, and we're still in the review process that has several layers. We've never received a federal grant of this type with the type of administrative expectation. So that's for me and my role, my goal, but there's others above me who make this.
And so as long as you include Chittenden County, I'll be happy.
I live there.
Well, there are people in Chittenden County in great need, and somehow there's got to be a link in this world across the state. Anyway, no, you don't have to respond to my comment. Senator Morley.
Just for my benefit, going back. Rulemaking. So we're not gonna develop standards or how it works. We give the authority, as I recall, to the Department of Health
Through the administrative
Rules Committee.
act. Is it Title III, Katie?
For rulemaking, yeah.
Yeah, Title III. So we give them the authority to make the rules. We have certain conditions that are lined up in the bill, and we can add or subtract. They write the rules with a public comment period, and people come in and they share what they think would be worth for this process. The rules are developed over usually a long period of time, but anyway, then it goes to ICAR, which is the administrative, the administration's rules committee. And they go to ICAR, and I think Sean Brown's still a chair. Anyway, they go to that committee. That committee from the whole administration looks at the rules and says, this looks good. And, you know, the Secretary of State ICAR. Then it goes to the Legislative Committee on Administrative Rules. And I was on that for many years, and, that committee then looks at the rules. They ask committees of jurisdiction, do these rules meet underlying statute?
That's, okay.
Chair signs off on that, yes or no? Ask questions. Then LCOG reviews the rules, looks at them, and will approve, disapprove, or say go back to the drawing board. And usually they'll approve by the time they get there. They're happy about it. At the time, very
So that's what's giving it its legislative.
authority
Right.
for it's done through rulemaking, implementation done through rulemaking. So we would have the choice of saying just this will just happen. No rules, nothing. We have the choice of saying that whatever happens specifically for certification, we have to write the legislation that will oversee that. That will take that. Or we put rules in place that allow for the administration to oversee it, and it sounds like they're already doing this for other things.
Well, thank you for that.
So, that's a good, that's quick and dirty, and I know I probably said 1,000 things that other people are gonna start correcting because of what you said.
Thank you.
May I add one thing to that?
Sure.
I think it has a far more comprehensive stakeholder engagement piece. I think that is really effective. So,
Okay.
we do, at least in my experience, I found that the substance misuse and substance use disorder continuum participates. So I would expect, a large swath of individuals to participate in that process, which I appreciate.
And the report that the chair committee gets contains all that
Information.
input. It contains the response from the department to that input. It's a big packet. Sometimes 3 and 4 of them come at a time, frequently in July. When these committees are. Right, when it's hot and sunny out. It's good reading. As long as you sit down. I read the public comments first and response. That's one of the first questions. I'm glad you brought that up, because that's one of the first questions that we ask in LCAR. Did you hear from enough people? Did you have enough public hearings? Yeah.
That answers that question. Yes.
That was it. That's a good question.
Anything else? Anything else for Emily? So your sense is the department has the capacity to do this work and follow through and, the folks in the. Absolutely. Thank you. So, yes, I'm looking around the room. Is there anyone else would like to comment at this point? Anything we left out? Once it goes to the other chamber, I'm sure there will be other things that added in. Oh, why did they leave this out?
Okay. Sorry, Candace Gale.
Please, yeah.
Yeah, from Vermont Foundation of Recovery. We had sent in an email, from Jeff, Moreau from VTAR or it was from Susie Walker from Recovery Partners of Vermont about a couple of small changes that are in the bill.
Did you copy Callista?
Yes,
And you did?
and the committee, yes.
Katie? Can we have that? Do you have comments that you can make right now that we could look at?
Sure.
That'd be helpful. Sometimes those emails get lost.
That's okay.
I do remember that.
You have it.
I have it, yeah.
You have it? Do you want to put it?
How should we do this?
Yeah, no, I'm like, I have it too. I don't know. Okay, so do
Send
you
it
want
to
me to just,
Callista
okay. I'm
right
sending it
now
to
and
Melissa
copy
right
it.
now.
Chair, make folks action circles. If you want Candace to just bring this up and.
Yeah, you can throw it up on the screen. We can share that.
Yeah, I'll see this.
Oh,
I don't want to show that.
Okay, here, so let me just Let me just email it to Melissa. I think that's easiest. So they can get it. Then I can change.
Gee, just give her. Give her.
I got it. You mind if I sit?
It's like getting a few cents, right?
Let's do. I just open this in and put it right on. Sure.
Will say, just thinking about Elkhart, what was the last big read was with a Medicaid eligibility for boys. I mean, that was a big read and very well.
Well, that's a, get through just natural. Does it impact small business? Does it impact school spending?
Maybe mute yourself.
I'm doing it. Sorry. It's open.
Well, we got there.
I'm getting there. I'm here. Okay.
Oh, look at you. It's great. Okay.
Okay. All right.
Huh. You can't read that.
I will read it.
Yeah, that's
Thank you for the hard and thoughtful work you're doing on behalf of Vermonters. I'm ready today to express RPV's support for S-157, the Department of Health suggested changes to achieve a medium option in providing guidelines to certified recovery residence operators without imposing undue burdens. We believe the changes will protect both residents and operators and enable the scaling of Vermont's recovery residence systems to meet the goal of 400 beds by 2030. Ensuring that the bill takes effect on July 1st, 2026, when the landlord tenant exemption sunsets, avoids disruption, and positions the resident operators to continue their success in providing safe, supportive recovery housing with accountability, distinguishing these residents from typical rental properties. Rulemaking would take effect on September 1st, 2027, as the bill states. The Recovery of Vermont supports the previously provided department language with these revisions, exempting recovery residences from section 4460 and 4464 of landlord tenant law in 9 VSA 4452B1. Adding volunteers to language in 9 VSA 4452B1AB and 9 VSA 4452B1C. And removing a reaffirmed after 7 days or modifying the language to reaffirming verbally or with signage in 9 VSA 4452B1B.
okay. And for the record, your name is,
Candace Gale, Director of Community Relations for
Okay,
Vermont
good.
Foundation.
this is great. So, yeah. Katie, do you have this language?
Yep.
Okay, so we'll do is we're gonna swap places and let Katie come up and then we can understand exactly what it is you're asking, how it's fit within the bill.
Sure. Should I stop sharing?
Yeah,
Okay, perfect.
here we go. Thank you for raising that.
Okay. So the first bullet point is to have, two new exemptions
Can
for.
we go to the bill to look at where they would fit?
Yeah, I was gonna bring you to the language that would be exempted. Would that be
Okay, let's do that.
Got it pulled up. Okay, so right now there are a few exemptions for recovery residences from landlord tenant law. If you remember, Cameron was here and he walked you through them. So what's being proposed is adding 2 more exemptions from landlord tenant law. The first one would be exemption from this 4460, meaning that the recovery residences would not have to follow this law. It says that a landlord may enter the dwelling unit with the tenant's consent, which shall not be unreasonably withheld. A landlord may also enter the dwelling unit for the following purposes between the hours 9 a.m. and 9 p.m. on no less than 48 hours notice, when necessary to inspect the premises, to make necessary or agreed repairs, alterations, or improvements, to supply agreed services, or to exhibit the dwelling unit to prospective or actual purchasers, mortgagees, tenants, workers, or contractors. A landlord may only enter the dwelling unit without consent or notice from the landlord till a reasonable belief that there is an imminent danger to a person or to property.
So you're asking for an exemption from all of that?
Okay. So that's the first one. Let me stop sharing and I'll pull up the second exemption. Okay, 4464. Here we go. Okay. Any tenant who sustains damage or injury as a result of an illegal eviction may bring an action for injunctive relief, damages, costs, and reasonable attorney's fees. A court may award reasonable attorney's fees to the landlord if, upon motion and hearing, it is determined that the action was not brought in good faith and was frivolous or intended for harassment only. So this would not apply to the tenants of a recovery residence if this was listed as an exemption. Okay. So those are the 2 exemptions. The other changes being requested, let me flip back to the bill. Okay. So, right now, this is the correct paragraph. The proposal would be, I think, it doesn't say where, but I'm assuming it would be to say, or volunteers right before this semicolon. So this is the signed document and this is listing, everything that's in the document. So indicating that by signing an agreement, the resident acknowledges the recovery residence may cause the resident to be immediately exited or transferred to an alternative housing if the resident violates recovery residence or substance use policy, regularly refuses to engage in services or programming, commits a crime, engages in theft, interferes with the recovery of other residents, or engages in acts of violence that threaten the health or safety of other residents or recovery resident staff or volunteers. And then the last piece. That was the last piece.
The reaffirming after the 7 days.
Oh, right.
We can pay it.
Where is that?
It's right there. You had
7, am I looking right here? Okay. Also part of the agreement, this is existing law that the recovery residence has obtained the resident's written consent to its residential agreement, reaffirmed after 7 days. The conversation, when this was adopted 2 years ago, was that sometimes when individuals come into the recovery residence, there's a lot going on for them, moving locations and so there was a conversation about requiring reaffirmance and going through the written agreement again after 7 days after somebody was settled. There may be reasons not to do that, but that was the discussion in the 2 committees a couple of years ago.
So what's the suggestion?
Either strike it or not have it be in writing, I believe. Yes. Question?
Yeah, no, go ahead, ask you.
Yeah, why?
Hand is.
Yeah.
Yeah, sorry. Why?
Yeah, Candace Gale, Director of Community Relations for V4. So basically we go over, we have the printed out material in their rooms. We do go over this after 7 days. Right now, there's an attestation that is sent after that 7-day period. And that is really cumbersome, especially for new operators to have to do the attestation when they're first going over all of the paperwork. And then reaffirming with another written attestation 7 days later, and then having to send that to VTAR to make sure that it's then like put in their file. We write it in the notes in our systems where we track everything. It's posted on the walls, all of the policies and procedures. So this is basically just saying, can we just say that we're reaffirming, reaffirming after 7 days, but we are doing it verbally, or with signage within the house, without having to go through a thorough process every 7 days, especially for new operators that aren't gonna have those systems built out.
Okay, thank you. I remember, this was a discussion. Is there a question here? I'm gonna give my comments right now.
Yeah.
Okay. We're very close to getting this bill out. What you brought to us, regarding those exemptions, I think there's something that can be carried to the House. I feel very strongly about that, that if we did that now, it would probably go to at least 1 or 2 other committees, which would be concerned regarding costs. So, and I understand your commitment and your interest here, but, we want to make sure that this goes forward. That's one. Interferes with volunteers. Interferes. That works. I mean, that makes a lot of sense. And then similarly with a written, that's a whole place where we have to have a longer discussion. Yeah. I'm sympathetic, I'm empathetic, I'm understanding. I really think that those 2 requests, are better taken up in House Human Services, honestly. Senator Moore.
I echo the chairs because I probably would have voted no. Just because it came in so late and I would have had to.
Not late. I mean, they could send an email. There's no late notice here. There's no late notice. It's a big thing to do at this stage.
That's what I'm saying, because if you're gonna go vote this out today, tomorrow.
But we don't, it could go to economic development and it could go to judiciary. Economic development.
Maybe economic development.
Yeah,
Yeah.
I don't want to go to economic development. It's really not their decision, but it does affect their jurisdiction. I'm looking at Department of Health and, listen, there's rulemaking in here. It could be that the House will start making decisions about alternative requirements for rulemaking that may affect landlord vendor issues. So there are ways of looking at this. Looking at Department of Health, these things that you want us to act on.
This is Jessica Shapano, Policy Director, Department of Health, and I think we don't have any concerns about them, but certainly like to mention about process. Things that warrant consideration. I do want to point out that the changes in the exemptions for landlord tenant law were in the original comments from before, and I think we have a walkthrough with that review still, but yeah, we don't have any concerns about the changes, but would be concerned with the process. Getting that process.
All right, my suggestion is mull this all over, given but if we mull it over, it will take more testimony. And it will take possibly another committee mulling it over as well. I mean, Senator Mills.
Agree with where you are. I think change to add The volunteers, I have no problem with that. You have concerns of opening up sort of Pandora's box on some of these other things that I feel would require a lot more discussion before I can come to things that I strike no sections.
I'm sure I agree with Senator Benson and with you, and I feel, especially with this language around the added administrative burden I get after 7 days. At the same time, I could foresee that, you know, someone might not take it as seriously if it isn't signed, sealed, and delivered. And I want to make sure that after 7 days, people have had a chance to settle in and absorb and do whatever's necessary to make sure that the process and the experience is a positive one. So I just worry if you don't make it, you know, codified that,
I agree, it's a protection,
yeah.
actually.
Okay. So I think we've got a majority of people who are agreeing to not add in the exemption at this time. It's not that it's not that we're not open to its consideration. So just to let you know that. That's where we are. I'm gonna suggest that. Are you here tomorrow morning?
Yeah, listed to schedule me on the Philbrook.
This might happen. So tomorrow morning, let's walk through the bill with the volunteers and then I hope we'll be ready to pass it for the full Senate, but really do. It's a good bill and it's a good start. Okay, we know it's a good start. There's a lot more that we could do. The House has all day. They're gonna improve it. Good, okay, thank you. And so now Jen is here. We have a joint assembly at where we're gonna adjourn at 10:15. We have a shorter. Thank you all. Thank you for your forbearance on our email world and also on our thinking positively about this bill. It moves so much. All right. Thank you for being here.
Good morning. Jen Harvey from the Office of Legislative Counsel. So yes, we are shifting gears.
So can I say one thing before we start on this? So, you know, as hospitals are going through the whole transformation work with the state health plan, they're concerned about, they're working together. In particular, some of the hospitals in the northwest and northeast kingdom are working together to find savings and efficiencies. But they're very concerned about challenges related to monopoly. So this bill has that information in it. Some people think we need it, some think we don't need it, but we'll hear from the hospital association. First, we need to know what's in the bill.
Great. All right. So yes, we are here to look at S-249, which is an act relating to hospital collaboration and state action community. And as the chair said, there are efforts with the hospital transformation work to have hospitals work together to find opportunities to share resources or provide services on a more regional basis. But there are concerns about anti-competitive behavior and antitrust liability. So that is what this bill is seeking to address. So S-249, an act relating to hospital collaboration and state action community. And sort of from a broad standpoint in antitrust law, there are some exceptions to antitrust liability when the state is providing appropriate supervision. And so the idea of state action immunity is that the state is sufficiently supervising the activity such that any outcomes are effectively the actions of the state or approved by the state. Then they are afforded immunity from otherwise applicable antitrust liability. So that is what this bill is seeking to do, is to provide kind of a framework for how to achieve state action. We talk a lot, even in some existing bills or legislation, about sufficient supervision, but what does that actually look like? And that's what I've tried to kind of spell out a path on that in this bill. So it starts out with intent. It's a new section in that would go in Title 18 in the chapter on healthcare administration, which is where a lot of fairly general healthcare implementation provisions go. Starts out with legislative intent that hospital and health system collaboration efforts that meet the requirements of this section be afforded state action immunity under applicable federal and state. There's antitrust laws at federal and state levels. So under applicable federal and state laws. And it specifies that this immunity is in addition to the hospital cost containment conduct that is afforded state action immunity under a particular provision. That's a provision saying if the Green Mountain Care Board tells a hospital, either directs them or authorizes them to do something specific in a hospital budget order and provides appropriate supervision of how that's implemented, that is already entitled to, or trying to have it entitled to state action immunity.
Just a clarifying question, so not an attorney. But we have the right to basically give immunity for federal law.
Yes, in the sense that the concept of state action immunity actually comes up, I think was originated at the federal level. And so, yes, what the federal government is saying in the state action immunity doctrine is states, you're allowed to do a lot of things on your own. And if you are kind of supervising to such an extent that you are in charge of the activity that would otherwise be anti-competitive, and the state, basically we're going to defer to the states if the states are actively supervising it. So yes, we can at least attempt to give state action immunity. There's certainly the potential that it would be, that the supervision would be deemed insufficiently active at the federal level. And there could still be, it's not a slam dunk. It has to actually be carried out in an active supervision kind of way. So yes, if all of the steps are followed for the state to say, here's what we're trying to do, we're trying to say, otherwise anti-competitive behavior is okay. If it is because we are actively supervising it and then the active supervision happens, then the courts have looked at conduct like that and said, it's okay because of the active supervision. It's a long way of saying yes.
But I follow where you're at.
That's, see, you're not a lawyer, but she is.
I went down the rabbit hole of law on this, working on the language.
So there's we have the VNAs are sort of allowed certain sections of the state. That's kind of
Yeah, I think that's a little bit,
It's like
I think that's a different concept, because there isn't necessarily the active state supervision requirement on an ongoing basis.
defined.
But I think we have provided territories, regions for the VNAs.
Senator Moreland, your comments.
I didn't know any of this. I was gonna ask the same question Senator Benson did. What's the risk if the federal law says you guys really didn't do what you're supposed to do at the state level? You shouldn't have allowed the hospitals to whatever, or you don't have it set up well enough or something like that.
Right.
I mean, I'm guessing it's low because I think we're gonna do a really good job as far as I'm concerned.
Well, I mean, I think it'll be helpful to see what the process is that's laid out in the bill, but the case law most of the case law is where, at least the case law that I'm finding, is where the feds have said it was not sufficient state supervision. And that's things like, where the state says, go for, like, if we were to say hospitals go forth and do whatever you want, because we've said it's okay,
That doesn't work.
that's not enough.
Right, right.
That's not active state supervision. And even to say, let us know you're working together and whatever you're doing is fine. Still doesn't seem to be enough, but for the state to have some sort of an active role, basically what they're saying in the case law is, if the state makes the anti-competitive behavior its own, so whatever the outcomes are, the state puts its imprimatur on it and
Yeah.
says, yes,
Then we're good.
state approves.
Okay.
That it's effectively the action of the state, even though it's private entities who are doing the actual, activities.
There.
So the liability would be on, I think, the hospitals. If our system was not sufficiently set up or we didn't actually do the active state supervision, I mean, it's the hospitals who the federal government would be going after.
Oh, I
Saying
thought it was carried down Karen work that.
So do you disagree with that?
No, I
Okay.
agree. It is the hospital.
So it's the hospital.
Well,
takes-
right, so the way I've set this up, it's a whole process with AHS doing the supervision. With some additional reporting going to the Attorney General's office. But if there were to be an antitrust violation, it would be, the people being sued would be the hospitals. Because the feds would be saying, you have engaged in anti-competitive behavior, and then the hospitals would say, no, we were following this state process and we were being actively
Okay.
supervised, so it should have been okay. And then it would be up to the court to decide whether our active supervision scheme that is set up and the execution of it was sufficient.
Legislation should draft it.
I don't want to understand what I was doing, so.
Senator Covey, no, I should say, I think the last time we did this was the right of, was it home care providers or child care workers to unionize? And they were individuals and they couldn't, I think it was the home care providers where you get to hire your own. But they wanted to unionize to negotiate with the state. And it was very controversial. It was child care providers at one point for child care workers. And the state had to say, we will supervise this. Because. Yeah, so which is what we need to consider.
Do you want to look at the language?
Yes.
I understood there would need to be some sort of, level setting on what we're talking about.
Right.
So that's helpful. All right, so we're starting out with our intent. The intent statement here is we're trying to do state action immunity, basically what we're saying. And here's how. So the qualifying conduct undertaken by, some of this was language given to me, so we may need to work with hospital association on terms, but undertaken by rural hospitals, community hospitals, health systems, or a combination for, and then these are the purposes. So this is part of what's important in state action immunity is having specific purposes for the purposes of cost containment, improved access to care, quality improvement, preservation of rural or community hospitals, advancement of the state healthcare delivery strategic plan once that's established, or enhancement of any existing healthcare initiative in a manner that is consistent with the principles expressed in 18 VSA 9371, sometimes called the Act 48 principles. So conduct undertaken by hospitals or health systems for these purposes shall be afforded state action immunity from, and I don't know if we need to specify, but under applicable federal and state antitrust laws, if the conduct meets all of the following conditions.
Can I stop?
Yep.
So it says, once the plan is established, so I'm modifying that because the state right now, the hospitals are changing within the plan process. So I'm talking about how we add the plan process and then.
Well, I think that is, I mean, the transfer, I think just saying as part of hospital transformation isn't specific enough. I think the purpose, so I was trying to list out the purposes of.
I agree. No, I understand, but having something about, this is a wordsmith that we can talk about another time, but just sliding in. That's my.
All right, so here's the conditions that have to be met. The Secretary of Human Services authorizes the parties to explore opportunities to collaborate to achieve one or more of those purposes. And the Secretary of Human Services deems any initiatives proposed by the collaborating parties as a result of that authorized collaboration to be consistent with the state's healthcare policy goals. And the Secretary of Human Services approves each initiative proposed by the parties prior to its implementation. And the agency actively supervises the parties' conduct throughout the collaboration and implementation. And that is spelled out more in subsection D. So that's qualifying conduct. Conduct that is undertaken by some combination of hospitals and health systems for any of these purposes, get state action immunity if all of these steps are met. You can go into some of these more. So then there's specifically authorizing information sharing. It says hospitals and health systems that are participating in discussions and collaborations that are approved under this section may share cost, utilization, workforce, and quality data as needed to achieve the purposes of the collaboration. And that information sharing shall not be deemed a violation of federal or state antitrust law.
That's good.
Then we get to the process for approval and what state supervision looks like. So subdivision 1, here's just sort of our overall construct. A hospital seeking to collaborate with another hospital or health system in a manner that the hospital determines may violate state or federal antitrust law shall seek approval from the Secretary of Human Services prior to engaging in that collaboration. And separate approval is required for the parties to discuss and explore opportunities to work together to further the state's health policy goals using the process you'll see set up, and for implementation of any initiatives developed pursuant to those discussions. So separate approval for the conversation and then for the implementation. So first we get to the conversation part. A hospital that's interested in exploring potential collaboration with one or more hospitals or health systems must submit an application to the Secretary of Human Services describing the proposed collaboration and specifying the manner in which the proposed activity would further the state's health policy goals and achieve one or more of those purposes that were at the beginning of subsection B. Then the secretary reviews the proposed collaboration and can ask for additional information or an informal hearing or both. And within 30 days following receipt of the proposal, the secretary can approve with conditions, or reject the proposed collaboration. Approval or approval with conditions constitutes the secretary's determination that the proposed collaboration is consistent with the state's health policy goals and likely to achieve one or more of those specified purposes. If the secretary rejects the proposal, the secretary's decision has to include the basis for the rejection and the ways that the proposed collaboration fails to align with or further the state's health policy goals or achieve any of those purposes. It also allows the secretary to order a hospital or health system that's doing a collaboration to obtain the services of a third-party aggregator or facilitator as a condition of approval at the hospital or health system's own expense. And then there's a reporting requirement. If the secretary approves a collaboration with or without conditions, the collaborators have to report to the agency of human services at least quarterly or more frequently if so required, describing material developments related to the collaboration and including any third-party reports if the collaborator, if an aggregator or facilitator was required. So that's getting approval for and what the collaboration process looks like. And then if the parties during the collaboration come up with initiatives that they want to implement that would further the state's health policy goals and achieve one or more of the specified purposes, then they submit a joint application describing those initiatives to the Secretary of AHS for approval. The application would include the names of the parties to the proposed initiative, how each proposed initiative would further the state's health policy goals and achieve, and then it lists those purposes again, or enhance an existing initiative or combination, the expected impact of each proposed initiative on patients, providers, payers, and the state, and a timeline for implementation. Then again, the secretary reviews the application and can ask for additional information or request an informal hearing or both. This one has 60 days. These are just numbers, so you can change timeframes, change any of it. But within 60 days following receipt of that application, the secretary would approve with conditions, or reject proposed initiative or initiatives. Approval with conditions constitutes the secretary's determination that the initiatives are consistent with the state's health policy goals and likely to achieve one or more of the specified purposes. The secretary rejects it. Again, the decision has to set forth the basis for the rejection and the ways that the proposal fails to align with or further the state's health policy goals or achieve any of the specified purposes. And again, the secretary can order the parties to retain the services of a third-party aggregator or facilitator. Then the quarterly reporting would continue or more frequently if required throughout the course of any approved initiatives. And this allows the secretary to revoke approval or require submission of additional materials at any time if the secretary finds that the collaborative conduct is inconsistent with state's health policy goals, is not on track to achieve any of those specified purposes, or materially deviates from the material from the original application. So they start going a different direction. And this allows actions taken in furtherance of a collaboration, either the conversation or the implementation, to occur without the presence or involvement of any state employees. They don't have to have AHS in the room at all times, as long as the parties report their activities to the agency as required, submit any additional materials reasonably requested by the agency during the collaboration, get additional approval from the secretary before engaging in any collaborative activities that exceed or deviate from those approved, and ensure that their efforts continue to be aligned with and in furtherance of the state's health policy goals. For the most part, except as specified in subdivision 2, everything submitted, all applications, reports, analyses, and other materials submitted to or generated by the Agency of Human Services in connection with a proposed, approved, or rejected collaboration are exempt from public inspection and copying under the Public Records Act, are presumed to contain proprietary or competitively sensitive information, and shall be kept confidential unless a hospital or health system specifies that any of them does not need to be, it should not be considered exempt and does not need to be kept confidential. Notwithstanding subdivision 1, AHS can make publicly available the fact of an approval and the general nature and purpose of an approved collaboration, as well as any finding that's necessary to demonstrate compliance with state policy objectives, as long as the agency tries to strike a reasonable balance between confidentiality of sensitive information and public interest in transparency. This also requires the Agency of Human Services to provide annual written notice to the Office of the Attorney General about hospitals and health systems whose collaborations were approved with conditions, rejected, or revoked during the previous calendar year, along with a description of the general nature. And it says that notice shall not disclose proprietary or competitively sensitive information that is protected under section D. Sections 2 and 3 I put in as sort of belts and suspenders, although there may be reasons to take them out. These are just specifically carving these arrangements out of the existing state laws on antitrust and anti-competitive behavior in the Consumer Protection Act. But there may be reasons not to, because it is so specific, and it does say in here, at least specifically under section 3, that where it says collusion is crime, and then it says, but that doesn't apply to the existing law. That subsection A does not apply when people are authorized or approved or required to work together by state or federal statutes or regulations. So that really should cover it, but there may be reasons to include it or not instead. And then finally, the act will take effect.
So I know this is a brand new concept that's come up. It's a long bill, has a lot of oversight and a lot of stuff in it. So the questions we want to first ask is this absolutely necessary to allow for hospitals to work together? And we'll have to get that answer from the hospitals, from AHS, from AG. The other question we have, does the agency have capacity to oversee this program? How will it affect hospitals' work? Will it slow down what's now happening? I mean, they've already saved $100 million, right? They're going to save more. We've heard that. And Then there's the exemption from the Public Records Act, which GovOps will want to look at. So there's a lot in this bill. But we've heard from hospitals, that some hospitals at least, that this is really necessary for their continued collaboration. So what I'm going to suggest is we let this one sit for a little while, come back to it, we'll try to understand it more. And let me know what your thoughts are, and we can talk about it, we'll talk about the bill. We might have some time to talk about it tomorrow, just our conversation. I know you can't be here. Are you here? Yes, you are. So
Here for something.
we may have time. We may and we may not. So we'll see how it goes. But we'll try to work it in. We want to hear from us about this. Senator Collmore did introduce it, and it was kind of the last minute for me to get it up on the agenda, so he wasn't invited. I was saying invited. He wasn't invited to testify, but I will. I'll talk to him. Quick question, because we have.
This is for you, actually.
Oh, God.
I'm getting across my brain here, the regulatory authority and oversight between AHS and Green Mountain Care Board.
Oh, good.
And
So let's.
because this is all AHS.
The way this is set up is AHS because AHS has been tasked with the transformation work and is working with the hospitals on their transformation activities. Where I put it in AHS, but it doesn't have to be AHS.
Yeah, but that I heard Wall Street
Yeah,
discuss.
we could put it somewhere else. We will have that discussion. Yeah, no,
I'm getting,
good question. It's a good question. No question about it. Yeah, so. Any other questions for Jen? Uh-oh.
Now, I understand hospitals need this new comfort level. Maybe not. But hospital transformation, there's our hospital transformation bill. And there is the rural health.
So we're gonna ask that question.
Okay.
We're gonna ask the questions. So,
Which
we
problem will be solved.
right.
oh.
Yeah. So I'm gonna bring closure to this, right? I think we have a lot to talk
Why
about
don't we
here.
just send this to judicial?
Huh?
Why don't we just send this to judicial?
No.
Oh,
Oh, no, we're not giving them our hospital information. No. Okay, thank you, Jen. I know it's a heavy lift all of a sudden for us. A lot in here and we'll have to sort it out. And we have Carolyn Sheridan here, from the National Organization of Rare Disorders. And Carolyn, we have about 10, 12 minutes.
Okay, I can do that.
All right, good. And we'll introduce ourselves. Well,
Good morning, Chair Lyons. Good morning, Senators.
listen over here.
Senator John Wally.
John Benson from Orange.
Jenny Lyons, Chittenden Southeast.
Our team, we're up to Chittenden Central. In Cummings, Washington District.
Good morning. My name is Carolyn Sheridan. I'm here from the National Organization for Rare Disorders, or NORD. I am joined by my colleague Jake Saltonstall. He serves as our community engagement manager, so he is deeply connected to the community. And we're also joined by Nordy, our zebra, which I'll tell you a little bit more about. I did send in some written materials to Lisa ahead of the meeting, so you can, kind of dive in at your own pace. But I just want to say I really am grateful for the opportunity to come and introduce NORD and Rare Disease Day and everything that we're working on in Vermont. So the rare disease world, rare disease is defined federally under the Orphan Drug Act as any condition that is prevalent within 200,000 or fewer individuals. That brings us to about 10,000 known rare diseases right now. And we're talking about 30 million Americans. NIH has a statistic where we kind of cite a 1 in 10 numbers. That comes out to a few thousand Vermonters. NORD was founded in 1983.
and it came out of the group of advocates, patients and caregivers that fought for the passage of the Orphan Drug Act. And so now we are a national nonprofit. We have a federation of membership, an umbrella style organization. We have about 350 patient organizations that are disease specific. And NORD represents the rare disease community as a whole. We like to say that our work is disease agnostic, and that alone we are rare, but together our numbers are strong, therefore we are strong. There's kind of like 4 main programs that state lawmakers really like to be most familiar with, especially if you have constituents that call in looking for resources. So NORD runs one of the largest patient assistance programs for rare diseases in the country. This provides direct financial support for patients for their medications and travel assistance. That's kind of one of our origin programs. That was actually run out of a garage of our founder back in the 80s in a little garage in Connecticut. And we're still doing that to this day. We also have an education team, which maintains a growing list of medically reviewed rare disease database. It provides information for patients and caregivers of a good couple thousand of the 10,000 rare diseases, and that's still growing. We also have a clinical network. We have it's pretty much like an accreditation program called the Rare Disease Centers of Excellence. And we have healthcare facilities. We're up to about 40 in that network now. And they're just designed to really elevate best practices for rare disease treatment, diagnosis, and multidisciplinary care. And then we also have our public policy team, which is where I serve on, going back to our origins with fighting for the Orphan Drug Act, continue to really try to drive policy to improve care and access for rare disease patients. And we are now operating with a fully remote workforce. So I'm based out of Albany, New York. My colleague Jade came in from Massachusetts. And we have staff all around the country, which really allows us to kind of be really responsive to kind of state specific needs and work. But Vermont is always my favorite state to come to for sure. And I'm not even kidding. So
We're always looking for people to live here.
I actually just purchased my first home with my fiance in November, and we really almost came into Vermont because we ski at Mount Snow and Okemo. But we did find one in there.
Oh, wow.
We were so close.
Whoa.
To give a little, I am here about Rare Disease Day though. And I'm actually going to be joined by a number of Vermont-based advocates later today. We'll be up in the cafeteria from 4 to 6 for an ice cream social. Yes. No. Rare Disease Day is observed annually on the last day of February. And the last day of February was chosen for Rare Disease Day because February 29th, the leap year, is the rarest day of the year. So it aligns very well. Yes. And the observance of that day began actually in Europe. And it became a global movement in 2009 when NORD became the US sponsor for that awareness day. The purpose of Rare Disease Day is to, provide awareness and promote equity and representation and policy. Landmarks, you'll often see them lit up in the colors of Rare Disease Day, which is pink, purple, green, and blue. There's patients and families that share their stories when we gather at state houses for awareness days. And you will also see a lot of what we call the Show Your Stripes campaign. And that is because the zebra is the symbol of rare disease. And that goes back to the 1930s. There's a saying in the medical community, when you hear a hoofbeats, think horses, don't think of zebras. Try to find the more common situation of what could be causing this person's symptoms. But in the rare disease community, we are the zebras, and we do need to be remembered. So the zebra becomes our mascot. And these are awesome. I will leave Nordy with all of you so that you can.
Oh, that's terrific.
Yes. So Rare Disease Day is a moment of visibility, but really what we're fighting for in Vermont, we've been fighting for with Representative Stone for the last 2 years or so, is kind of a vehicle for Vermonters to have year-round structural attention as well.
Vermont is considering right now H46, which the House passed last session.
Which is right up there.
Yes, yes, it is. And that would establish the Rare Disease Advisory Council, which would be housed throughout within the Department of Health. I do look forward, I'm going to be coming back in April, again, with another group of advocates. And we are hopeful that by that time, H46 might be up for discussion. And then you can meet some of these Vermonters and folks with rare diseases yourself. And then we can explore, right, how we might be able to continue strengthening year-round support for Vermont.
Good, thank you for that, and, yeah, we probably will take a look, we will take that bill then.
Thank you, Chairman.
So do you have a list of the rare diseases that we can look at? I mean, as we pick the bill up, we're gonna wanna know what diseases are there, and then what's here in the state of Vermont. I know I've talked with a few people about some of the rare diseases, and there may be others. And then what's not included. I mean, right now we have long COVID, long Lyme, we know that how is it defined? So,
Yeah, so
Yes.
many of like infectious diseases like that are not necessarily counted in that definition, but the known list of 10,000, there is a database through NIH. There's a database through GARD, GARD, and then NORD has a database as well, which has about 1,000 of the 10,000. But it is a very large number and many are growing. The majority of many rare disease conditions are genetic in nature, for sure. There's all pediatric cancers are considered rare as well. And many rare diseases are prevalent in children, so there'll be a lot of pediatric rare diseases.
good, thank you, thanks for this, it's a good introduction.
Yeah.
And I know we'll probably see you back, after we can take a look at that.
I hope so. Thank you so much, Senators. Thank
Thank you, thanks for coming, appreciate it. All right, committee, we have